Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 363 of our pharmacotherapy series, which majors in chronic obstructive pulmonary disease. The next case reads, PRL, a 66-year-old man with diabetes mellitus and severe, that is Group C, chronic obstructive pulmonary disease, presents with increased cough with productive discolored sputum after a cold. He had been hospitalized 6 weeks earlier with community-acquired pneumonia. He is a former smoker, who quit 10 years ago. His current medications include tiotropium respimat 5 micrograms once daily, albuterol metered dose inhaler 2 puffs every 4 hours as needed, and theophylline 200 mg twice daily. He also has increased dyspnea and chest tightness. On examination, he is in no acute distress and vital signs are stable. There is increased wheezing on chest examination, and the rest of the examination is unchanged. Room air pulse oximetry is 90%, and a chest X-ray in the office shows no infiltrates. So my question to you reads, how should this patient be treated? This patient has increased sputum purulence and increased dyspnea consistent with an exacerbation of chronic obstructive pulmonary disease. It is not uncommon for such an exacerbation to be triggered by an upper respiratory viral infection. Given that the patient has increased dyspnea and purulent sputum production, a course of systemic corticosteroids, e.g., 40 mg of prednisone daily for 5 days, and a course of antibiotics is warranted. In outpatients with low risk factors, a low-cost antibiotic regimen is a reasonable option. Empirical treatment with an aminopenicillin with or without clavulanic acid, a macrolide, or tetracycline derivative such as doxycycline may be used. Although other antibiotics are commonly given, no data support that they are superior in this setting when compared with these conventional, less expensive agents. An acute exacerbation of chronic obstructive pulmonary disease is one of the few instances in which antibiotic therapy is warranted to treat a respiratory infection in the absence of evidence of lower respiratory tract involvement, i.e., pneumonia. Patients with chronic obstructive pulmonary disease and risk factors for poor outcome, severe chronic obstructive pulmonary disease, comorbid conditions, history of frequent exacerbations, may be more susceptible to resistant pathogens. As such, guidelines recommend that a broad-spectrum antibiotic regimen be considered, including beta-lactam beta-lactamase inhibitor combinations, quinolone antibiotics, or second or third generation cephalosporins. Because of his recent hospitalization, PRL is at increased risk for resistant pathogens, including Pseudomonas aeruginosa. He also presents with increased sputum purulence and increased dyspnea, so a broad-spectrum antimicrobial regimen, such as oral ciprofloxacin 750 mg twice daily or oral levofloxacin 500 mg every day for 5 to 10 days would be appropriate. A course of oral prednisone 40 mg daily for 5 days is also indicated to improve PRL's lung function, reduce his hypoxemia, and hasten his recovery time. The next case reads, PRL was treated with oral ciprofloxacin 750 mg twice daily and demonstrated a decrease in sputum volume and purulence with less dyspnea after 3 days of therapy. However, 5 days later, he is feeling palpitations and has become nauseous. My next question to you reads, what laboratory value should be checked? This patient has clinical evidence of theophylline toxicity. Both gastrointestinal complaints, e.g., nausea, and CNS symptoms, including sleep difficulty and nervousness, are consistent with theophylline toxicity. Other adverse reactions associated with methylxanthines are cardiac irritability, tachycardia or arrhythmias, and seizures. All these side effects are dose-related. Gastrointestinal intolerance, nervousness, and insomnia can occur at any serum concentration, but increase in frequency when serum concentrations are greater than 15 micrograms per milliliter. In PRL, the addition of the antibiotic ciprofloxacin to his regimen most likely resulted in a drug interaction causing a rise in his theophylline concentration. The potential for an interaction with theophylline varies among the available fluoroquinolone antibiotics. Drug interactions are dependent on several factors, including the dose of each agent and the baseline serum theophylline concentration. Elevations in the theophylline concentration of 25% are typical with ciprofloxacin interactions, although elevations of 50% have been observed. In PRL, a theophylline concentration should be obtained and further doses withheld until results are known. In general, theophylline metabolism is associated with significant interpatient and intrapatient variability. Patients should be monitored closely for early signs of toxicity, as well as for the initiation of drugs that potentially may interact. Understanding and recognizing the potential for drug interactions can allow safe and effective therapy with theophylline. A theophylline serum concentration is measured for PRL. It is reported as 21 micrograms per milliliter. So my question to you reads, what action should be taken? The serum concentration is consistent with the interaction between theophylline and ciprofloxacin reported in the literature. His symptoms do not appear life-threatening at this point, so a conservative approach to treatment is appropriate. Theophylline should be withheld for 1 dose and then restarted at a lower dose, 100 mg twice daily until the ciprofloxacin therapy is completed. Alternatively, theophylline could be withheld until the antibiotic treatment is finished or discontinued. As mentioned, theophylline has a narrow therapeutic index and has the potential for serious toxicity, as is evidenced by the current case. If the patient is unclear how beneficial the theophylline has been, a trial off of the medication is reasonable. After approximately 2 to 4 weeks, PRL should be reassessed. If he feels that his chronic symptoms are no different without the drug, it should be discontinued. On the other hand, his symptoms may become more pronounced without the theophylline, and it could then be restarted. Alternatively, it would be reasonable to replace theophylline with an additional long-acting bronchodilator from a different class, in this case a long-acting beta agonist. Evidence suggests that the combination of a long-acting anticholinergic and a long-acting beta-2 agonist can increase lung function and reduce hyperinflation compared with either agent used alone. Salmeterol and formoterol have a similar side effect profile and have similar effectiveness, the only significant difference being that formoterol has a more rapid onset of action. Either salmeterol, 1 inhalation, that is 50 micrograms, every 12 hours, or formoterol, 1 inhalation, that is 12 micrograms, twice daily, would be reasonable options for PRL. Chronic obstructive pulmonary disease has a progressive course, highlighted by a worsening of symptoms with time. Because stepwise therapy is recommended, it is not uncommon to find patients on multiple medications added on in an attempt to alleviate symptoms. Nevertheless, it is important periodically to assess the patient to determine whether all the medications are continuing to provide symptomatic benefit and are still needed. This may result in a step-down approach. P.K.J., a 62-year-old man with long-standing chronic obstructive pulmonary disease, presents with worsening dyspnea on exertion. He is currently prescribed combination fluticasone salmeterol, marketed as Advair 250/51 puff twice daily, tiotropium, marketed as Spiriva 18 micrograms 1 puff every day, and as needed albuterol, 2 to 4 puffs every 4 to 6 hours as needed. PKJ reports excellent adherence with his medications, and an evaluation of his inhaler technique reveals he is able to use all 3 devices correctly. He has undergone pulmonary rehabilitation in the past with some benefit. He is no longer exercising, however. He has smoked 1.5 packs of cigarettes a day for 40 years. That is 60 pack years, but quit 1 year previously. His most recent forced expiratory volume in 1 second to forced vital capacity ratio is 0.41, and his forced expiratory volume in 1 second is 1.25 liters, or 38% of predicted. His room air oxygen saturation at rest is 85%. On examination, reduced breath sounds are noted in his chest and he has lower extremity edema. His physician recommended supplemental oxygen. However, he is resistant and wonders what kind of benefit he might receive. The Nocturnal Oxygen Treatment Trial, abbreviated as NOT, a randomized controlled study, studied patients with chronic obstructive pulmonary disease and severe hypoxemia, that is, arterial oxygen pressure equal to or less than 55 mm of mercury, or arterial oxygen pressure equal to or less than 59 mm of mercury associated with polycythemia or peripheral edema. Patients were randomly assigned to receive continuous oxygen or nocturnal oxygen. The primary outcome variable was mortality. Subjects using continuous oxygen had a significantly greater survival and improved end organ function, including improved cognitive function. The Medical Research Council study published in 1981, using similar entry criteria, demonstrated a significant survival benefit with continuous supplemental oxygen compared with no oxygen. On the basis of these studies, supplemental oxygen is currently recommended for severe hypoxemia, currently defined as an oxygen saturation less than 88% or equal to or less than 55 mm of mercury, oxygen saturation less than 90% or equal to or less than 59 mm of mercury in the presence of polycythemia or clinical evidence of pulmonary hypertension, e.g., peripheral edema. These guidelines are used by Medicare and most insurance companies as criteria to determine coverage for supplemental oxygen. This patient should be encouraged to use supplemental oxygen because it is one of the few available interventions that has been associated with improved survival in chronic obstructive pulmonary disease. In addition to supplemental oxygen, the patient should be re-enrolled in pulmonary rehabilitation. As mentioned, existing data suggest that this intervention can improve quality of life and exercise tolerance and decrease healthcare utilization. The next case reads, PKJ is prescribed supplemental oxygen and enrolls in a pulmonary rehabilitation program. These interventions are successful in improving exercise tolerance. However, he presents 12 months later complaining of worsening dyspnea. In addition, although he is compliant with the oxygen, he is wondering whether any other interventions available might improve his lung function and allow him to get off of oxygen. He is re-evaluated with pulmonary function studies, which demonstrate a reduced forced expiratory volume in 1 second to forced vital capacity ratio of 0.38 and an absolute forced expiratory volume in 1 second of 29% of predicted. In addition, lung volume determinations show severe hyperinflation. TLC is equal to 135% of predicted and air trapping RV equal to 292% of predicted. His chest X-ray shows a marked decrease in lung markings in the upper lung zones with vascular crowding in the lower lung fields. What therapeutic options are available for PKJ? Lung volume reduction surgery, which involves the surgical removal of approximately 30% of the volume of each lung, can significantly improve quality of life, exercise tolerance, and mortality in selected patients with chronic obstructive pulmonary disease. The National Emphysema Treatment Trial, abbreviated as NET, demonstrated that patients with severe, upper lobe predominant emphysema who have lung volume reduction surgery have significant benefits in health-related quality of life as well as exercise tolerance. Subjects who also had persistently poor exercise tolerance before surgery appeared to have the most benefit compared with control subjects with similar impairment. These patients also had a mortality benefit. The rationale for the surgery is that removing the areas of the lung most involved with emphysema can improve the physiology of the remaining lung. This includes improvement in expiratory airflow and improved lung elastic recoil as well as improved ventilation perfusion matching. After a successful surgery, patients can have improved gas exchange and may no longer require supplemental oxygen. The chest X-ray for this patient suggests upper lobe predominant emphysema. This would need to be confirmed with a high-resolution computed tomography scan of the chest. Furthermore, the patient would need to complete a comprehensive pulmonary rehabilitation program before surgery. Only a few centers within the United States are certified by Medicare to perform lung volume reduction surgery, and this could be an important issue for PKJ, depending on where he lives. It should be stressed that lung volume reduction surgery is only appropriate for a select group of patients with advanced emphysema. In patients with severe emphysema, another option is lung transplantation. This intervention has not been shown to decrease mortality, but can improve quality of life and exercise tolerance in carefully selected candidates. Patients considered are those with severe disease, whose life expectancy is less than 5 years, and individuals with enforced expiratory volume in 1 second less than 25% of predicted. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 364.